Ladies and gentlemen, thank you so much for attending this talk. This discussion is going to be on the transformational role of artificial intelligence in treating behavioral and mental health. This is the main topic that deals with current situation, people in lockdown, quarantine, and all that. I am Dr. Atif Farid. I am a professor of artificial intelligence in adjunct capacity at UNC Charlotte. Also, I'm a senior research scientist at Ontrak Incorporated. I have shared my LinkedIn connection, so you are most welcome to add me. You might have to send me a note where actually we met. So let's begin this presentation. So, what artificial intelligence deals with? We all live in human intelligence era since the day of the dawn of human beings. However, artificial intelligence actually started way back in 60s, where computer was evolving to resolve things virtually in compute capacity. So AI makes machines capable of learning from experience, adapt to new inputs, and perform tasks requiring human intelligence. Again, it's us humans who inform machine how to interact. And like you can see in this pictorial representation, there is an agent. An agent requires a condition action. Condition action could be coming in as an input from sensors, how the world is like now, actions to be undertaken, effectors, so some sensors to effectors. There are percepts and actions which produce some sort of output within an environment. And like you can see in this pictorial representation, there is a Google car which takes snapshots of its 365 to create Google Maps. So let's go further. The AI applications, they deal in two domains. First domain is the analytics domain. The other domain is the machine learning domain. So you might say that analytics or machine learning should be one. They are two entirely different domains which are combined within the artificial intelligence bigger domain. So AI deals with predictive analytics, deep learning, machine learning, whereas the classification, translation, or data extraction happens under the banner of natural language processing. AI also deals with text-to-speech, speech-to-text, and you might have seen the Skype or Google Dialogflow. These are few speech-to-text, text-to-speech translators, interpreters. And then the other domain is expert systems. Expert system is to make a decision whether this project is a go or a no-go, whether how many further Scrum cycles we need to complete the project requirements from the users who are involved. AI deals with image recognition, machine vision, and that is vision in terms of that how we as humans see something, and then how we as a human say something or understand something in terms of speech. Machine learning is in terms of human learning. And then data extraction, translation, and classification are needed when we are listening to someone. The first of the thing that comes to our mind that what that person is saying. I am flying. If I say this, as a human, you might say, no, you're not flying, you're sitting in a chair. Whereas I'm saying I'm flying in the high thoughts of some sort of Zig Ziglar or Tony Robbins book. Or it dawned on me when someone has told me this, this, and this. So that example classifies that I'm flying in the thoughts flight is technically a metaphorical flight, not a physical flight. I am as a human cannot fly, obviously. Expert systems deal with the making of a decision whether this is a go or this is a no-go, this is good, this is not good. Again, artificial intelligence bases on computer science. Computer science is based on 0 and 1, which is the computer science era. See you at the top. Yes, absolutely. You are right, Dan Barry from Zig Ziglar. See you at the top and See You from the Top are the two most important human intelligence books that one must go through. Planning and optimization, then we plan accordingly. And as Zig Ziglar says, if you don't have a goal, how you will hit it. So I am in total understanding and acceptance of that idea. Robotics is the thing that we are headed to. That means the auto-driven car, self-driven car is a robot. Anything that has some certain functions to perform without any human intervention can be considered as a robotic process. Let's move on to the next slide. So you can see that there is a image source given underneath. You can look into that. A little bit of AI history. The Turing test, or the famous father of computer science, Alan Turing, created a test whether a machine is capable of human intelligent behavior or not. That is 1950. 1955, John McCarthy, an American computer scientist, coined the term artificial intelligence. So this is coming in from a little while since 1955 onwards. The first robot is introduced on an assembly line by General Motors in 1961. So you can simply understand that AI, or artificially intelligent robot, has a function. Do this, do this, do this. That's it. There is don't do this does not exist until there is a malfunction within the robot mechanical system. If we take 1961 to 1965. 1965, Eliza, the first chatbot, came out from the MIT AI library. I have been to MIT. I'm an MIT systems architect certified. So I have seen firsthand quite a few things at MIT in my tenure there in 2007. And in 1965, they came up with Eliza. So that's the first chatbot which understood human speech. IBM's Deep Blue, a chess-playing computer that actually did beat a chess world champion, Garry Kasparov, was 1997. So imagine we are in 2020 or 2020. So we are way advanced at this moment currently. So let's go and look at the next slide. Before I go to the next slide, machine learning or artificial intelligence algorithms start from naive algorithms, and that expands into machine learning, and then goes into deep learning, and then deep reinforcement learning, and leads to distributed agents formed deep reinforcement learning. What is reinforcement learning? Just a little primer that when we need energy, we either need water or we need food to energize our body to go and do something. Computer needs stimulus in terms of information, in terms of data, in terms of planned algorithms which translate the data into information and then later actionable items. So next slide. So you can look into that training data comes and that trains the machine learning algorithms, and a model is then adopted and the input data comes in after. So you might say that how is that possible? It is pretty straightforward thing. We all live in a universe where we deal with metadata on our everyday life. Metadata does not need data. A university does not need students. However, it has students because it works for students only, and all the entire environment is there to serve the student population. However, before university inception happens, they need metadata extracted that the student would be first name, middle name, last name, some address, some sort of qualification achieved, then we'll give that student admission. So you can imagine that there is a whole process associated with that. So since I deal with the healthcare applications, so you can look at that. The artificial intelligence service trained on more than 500 million service lines, making up to cover 205 million unique claims. And this data is of 2019 or previous, as mentioned in the image source. And you can see that the last box has that 35% of these claims were denied out of 6.2 billion claims. So what was the input? All the documentation. What was the observation? Whether those are legitimate claims, semi-legitimate claims, or fake claims. And in 2018, 23.21% of all these service lines were denied. Over 62 billion in charges was something that came out of the machine learning algorithms within the artificial intelligence domain. So this is the process flow that this slide put light on, that when we have an input data, if we go through standard input process output way as a computer science way, that means machine learning algorithm goes and predicts something. Manual validation by humans happen on the test data, which is very small percentage of the data. If the data is 100, then human can only validate 1 or 2 or maximum 3% of the data by human sight. Look into that. And that, once validated by the human, went into the training data set, merged into training data set, and then training happened of the machine learning algorithms on top of that. And this cycle carries on, is exactly like agile methodology. So let's look into that a little bit more depth, that AI and data science merger. There are development tools, there are data ingestion tools, data exploration tools, and visualization, ML and AI, deep learning, virtual machines, data platforms, and languages. Now again, if we go into deep, there are C++, C#, Julia, R, Python, JavaScript, or any other languages. They are all different languages with different algorithm design styles. However, in the end of the day, we look at mathematics as x plus y is equal to z. So if we look into this next picture, the AI and the big data has to merge, because the data is coming in with the velocity, extreme velocity, with veracity, and we need to process that, and that can only be processed if we have big data clusters available for us in terms of Hadoop, like Cloudera and all those other Hadoop, we can say vanilla. We call it Hadoop vanilla versions, which are open source. And you can look into this typical picture. The AI is implemented on top of computer vision, natural language processing, and generative models. However, this goes back and forth. The data comes in, and the insights get out in terms of who should be treated, who should not be treated. So standard machine learning employs data mining. The data mining enables deep learning. And again, the whole combination of analytics, business intelligence, statistics, and data visualization play a vital part in this entire AI and data science merger. Next, let's look into the original data set. When we have original data set in any capacity, for example, if we are working with the oil wells, or if we are working with the health related data sets. So now you might think, what is the relation between an oil well and a health data set? Oil wells have metadata associated. Human health has metadata associated. Computer does not distinguish between an oil well data, Walmart data, Under Armour data, or human health data. Computer deals with the zeros and ones. AI deals with the algorithms. So the original data set, whether it's oil well data, shopping data, or health data, needs to be divided into a training set and a test set. Then in training set, we also further subdivide validation set and test set and training set. And then we apply the standard training, tuning, and evaluation of those data sets to training and validation data sets within a predictive model to extract actionable insights. So let's go to the next slide and see what we have there. The artificial intelligence diagnosis. Again, AI data requirements, as I just mentioned, that AI does not know what it is dealing with, as it might be oil fracking data, it might be Olympics athletes performance data, it might be the human health data related to mental health, behavioral health, or in general health, or perhaps fatal health, fatal heart failure, congestive heart failure, or other social determinants of health. This entirety is under the big arc of modeling, and modeling goes from system to a model, and that model needs stimulation in terms of data, more data and more data and more data to predict some observations, to compare and contrast, to detect whether the diagnosis is possible, it is correct, or it is incorrect. And all that happens on the Bayesian knowledge, applying the application of probability and inverse probabilities. So this is extremely important to know, that AI data requirements needs the max data available to start working on something. So data requirements, let's dig in a little bit deep. The data science hierarchy needs AI deep learning. However, the beginning starts from the collection of the data set. That means instrumentation, logging, sensors, external data, user-generated content. Again, user-generated content is X plus Y is equal to Z is an algorithm, whereas X can have 100, Y can have 200, and then Z would be 300. What if X has minus 100 and plus Y has plus 100? The Z would be 0. So that is a generated data set. The move and store, we need reliable data storage in terms of Amazon Web Services, Google Cloud Platform. These are two reliable areas where we put the data sets. And usually if we are dealing with the healthcare, then they need a private cloud within the organizational hierarchy, and high trust is needed. So explore and transform, that's the data warehouse processes, cleaning, and anomaly detection, and data prep. Analytics, metrics, segments is the aggregation and the labeling. And then that goes to A/B testing, and then the application of AI and deep learning allows us to find the actionable insights. So data requirements vary significantly. You can see the new data is coming in. That can be anything. It needs data variety checked, data quantity checked, and now data quantity, how many students, and how they have to taken how many courses. One student might have taken an N number of courses, 9 courses, and one student might have taken 33 courses. What's the difference between that? Geo-dispersed and on-prem and cloud, that is the data set that we deal with in our current Amazon Web Services and Google Cloud Platform. Data efficiency, whether we don't have tons of distorted data, that will allow us to go into more detail search for the real data set and remove the demurrage, which is the bad data that is coming in. Then data prep needs, data quality, and data gravity. HDFS and Spark are the 2 examples. There was a question came, Mycian was one of the early healthcare artificial AI and expert systems developer. Yes, absolutely correct. Bill, you have brought in the right add-on, the beginning 1972. Why didn't it gain the acceptance in clinical practice? Because computer was not widely accepted in 1972. That was one of the reasons. Second, there is a skeptical thought process that goes when we get brand new thing. people usually tend not to follow that thing right away unless they see some other people fail or be successful. So that's my rationale. However, I usually, as an AI professor, I tend to accept and try to work with the pros and cons of the AI system if I get any. So the model velocity, workflow integration, data access density, these are few of the features that are needed to inference. Inference is actionable insights. Let's go next, and what do we have over there? AI in healthcare. So AI in healthcare is technically, that's our domain that Ontrak incorporated, or the organization or work as senior research scientists. We employ artificial intelligence, and that is we work with assisting in monotonous tasks. That means to find out which health plan data has what features that they like us to provide the actionable insights. That's where our algorithms go and dig in deep and find out actionable insights customized towards a certain health plan. So the AI algorithms to mimic human cognition in the analysis of complex medical data. Now we cannot place someone with tuberculosis in a healthcare in the heart health capacity, or in some other like blood sugar level capacity. So COPD, anxiety, depression, they are all treatable comorbidities. However, they are in their own domain a huge area of research. So anxiety by itself is a huge area of research, and intense research has been conducted by several organizations on anxiety, whereas anxiety tends to depression, and depression can go into further some suicidal thought process. How to correct that path of someone to bring that person back to real life and back to the normal life is the Ontrak Inc.'s main job. So the purpose of AI's utilization in healthcare is personalized patient treatment plans, improve patient care, increase operational efficiency. And you can see that we have now all those Apple Watch and this and that trinket that we have in our life going along, and that can actually, our cell phone monitors our steps and the miles that we do in a day or so. And if you are using Under Armour biking on a road app, then it tells you how many calories you lost, what was your start point, what was your end point, what was your highest speed, what was your speed with the brakes and all that. So they are all AI on the back, and they're working for us as a human. So the mental health application, as you can see in this word cloud, it is extremely important for us to be aware of our own mental health. Mental health is tends to do self-harm. It puts us in grief. It enacts stigmas, phobias, anxieties, and attitude issue that we have in everyday life that we feel that needs to be treated. So there are several treatments. Few are with the medication, few are with the therapy, few are with making sure that person is adapting the better lifestyle towards his or her benefit and becoming on track as he or she was previously when he or she was healthy. AI for mental health, you can look into this detail that unlike a psychiatrist who wouldn't appreciate being woken up during the odd hours of the night, an AI-based empathy tool would always be available to interact with, especially during the emergency. So this is another Bill's your answer coming in, that why people were not very happy, that they thought that AI will take their jobs away, and that was one of the fear. False evidence appearing real, as Tony Robbins say. So the second would be 24/7 availability is okay for us. We live in that domain. We have our cell phones that can talk to us. AI can monitor signals to predict mental health issues before it even arises, enabling timely prevention or preventive care. That is the improvement of predictability for someone who is going down the drain due to some anxiety or depression or some other mental health issues. The greater accuracy, if we walk every day a mile, let's say with fast pace, and we do have a trinket that tells us, and then after 3 days, if we don't walk, or if we walk slow, then that's a marker of some sort of being tired, or some sort of being the body is not performing accurately. That's where these apps data can be very helpful for a practitioner to help the individual who's facing some sort of issue. Address the social stigma, the social taboo associated with seeking mental health diagnosis can deter people. So again, the AI's artificially intelligent agent is technically someone who we can trust, rather than as a human when we are restricted not to tell our actual feelings to that human. Reduce costs, obviously, as opposed to the psychiatrist, the charge consultation fee and all that, AI-based tool would be very less expensive. However, I'm not saying that the psychiatrist's job is gone nuts. No, they are absolutely needed. Support empathy, empathetic therapy from a software would be hitherto non-existent option for people that lack a human support system or close confidants. We have seen, and Ontrak, there are so many people who live alone and they don't have anyone to talk to. Either they don't have any siblings or parents or close relatives, or they are in a disconnect with those folks for some odd reason. So AI mental health care, this is an example application, and I have utilized this with a team of mine, and we apply this framework. This is called the application of the GRU, which is Gated Recurrent Unit, a system of gates that controls information flow within the network. This is exactly as a dam which releases water in a certain capacity to generate some electricity or to keep the water in a reservoir. So that's the human understanding of gated approach towards what information should be given, what information should not be given, whether it's positive information or it is negative information. So like this is an example. I'm interesting and likable enough. I don't do well at parties. I'm not interesting. Positive and negative. However, what about both positive and negative, and neither positive or negative? The example for both positive and negative is I chewed my fingernails and did some skin picking. I tried doing some of the breathing exercises which worked while I did them. That's positive and negative. Whereas neither positive nor negative, I wrote in my journal and read till I was tired enough to fall asleep. So you can see these are the examples. They are the examples of gated recurrent unit system, and that controls information on within an app, which is an AI agent. Another example would be I chewed my fingernails and did some skin picking. You can see that this is a haphazard discussion from someone. However, this shows that mental health of that individual and the gated or controlled information flow allows us to make a positive or negative decision. So, okay, I don't consider Zig Ziglar, Tony Robbins credible commentators. I agree they are in a different domain, Bill. I agree in that aspect. On AI, in any capacity, they're all about motivation techniques and increasing sales. Obviously, selling is something that happens in positive way or negative way. And I agree with you that they have no influence. However, I'm just sharing a human understanding and on that level. And then when we go into the level of artificial intelligence, where Alan Turing comes in, And that's where the human behavior translation into a machine behavior translation, that's where human behavior depicted in any way would be positive or negative. So what healthcare AI researchers have made greatest contribution, the greatest contribution are happening within the domain of healthcare in several places, and I'll share that with you in just a few moments. So a very good question, very timely question. You will be having some answers in next couple of slides. So the Ontrak program, Dr. Pete Burse, Dr. Scott Denning, Dr. Arsen Gregorian, me, and there are other people, Dr. Julie Wright, and there are a couple of Google researchers involved. They have all looked into the identification and engagement of the Ontrak AI virtual agent to work to find a treatment to save the individuals from the happenings of their own wrong or right doings. Right doing is we like some food, however, we carry on eating it as long as we are full, but we are not interested to leave that table until we finish that, even though we might have a bad stomach after that. So let's go further. Loneliness is something that we came out in the general discussion that we recorded and transcribed, and that we found that the feeling of sadness and unhappiness about being socially isolated was one of the things that came out in major, and that was self-isolation, decreased ability to function, diminished a sense of self-esteem. So these are the things that came out in the findings of our discussions with the patients that we work with in our organizational settings. And that's where we found out, after conducting Dr. Pete Beers and Dr. Omar Manijwala, Dr. Julia Wright, they are the researchers who figured out that an estimated age of 1 in 3 adults over age 45 suffers with chronic loneliness. And according to a 2018 survey that I found from the AARP Foundation, this data was pretty much the similar. The poor social relationships had been associated with 29% increase in the risk of coronary heart disease that could easily lead somebody into congestive heart failure. So these are a few of the things that we are working at Ontrak. And here is another example I just shared with you, so I'll skip this. I will skip this because I just mentioned that earlier. So we recognize loneliness as a key social determinant of health that is focused on identifying and addressing the fundamental drivers which differ by individual, and our AI agents found out in the discussions that we had for 7 years worth of data set within the Ontrak capacity intellectual property, that loneliness was affecting on a very big note. So I will leave these slides because these are just the examples of the role of AI addressing the loneliness. So let's go to the next one. Here is some data set that I would like to share with you. The word pain, anxiety, alone, depressed, lonely, the count was this, and when I say 17.5 is in millions of 7 years worth of discussions. The bigrams were live alone, chronic pain, and that was into, again, 15 to 20 million of those words were found in the discussions. So the challenges in AI for healthcare are this: we have found the asking the right questions, lack of prior agreed upon criterion for high dimensional data maybe effectively utilizes AI capabilities. We have found that these questions relevant collection of high quality data, because high quality data is still unavailable, is not very much available because of the transcription that happens between two persons speaking. As there are times when this is distorted due to our standard lines, and very heavy population even in the United States has landlines, not the cell phones. Not all of them have cell phones. So that distorts data that is not high quality data. AI tasks must undergo extensive evaluation to determine their clinical efficacy and safety. Need for standardization. We have not found so far till date any standardization available for natural language processing to deal with the human discussions. Adapt AI supported insights to support physicians and do not overwhelm clinical teams, because nurses and psychiatrists or the therapists are usually shorthand. They have less staff, they have more patients, so we need to go and set some trends within the AI supported insights, that is the actionable insights. Need to understand technological and medical limitations for employing AI in healthcare, avoid misconceptions and hype for the AI capabilities. So thank you so much for your time. It is much appreciated. And now I will take the questions. I would like to go back to answer Bill's question. I don't consider Zig Ziglar and Tony Robbins credible commentators. I agree on AI and in any capacity. I agree in totality, and that is where I said human intelligence, not the artificial intelligence. They are all about motivation techniques. Motivation techniques is extremely important. We need to motivate an individual when we are dealing with the healthcare in terms of mental health, behavioral health, emotional well-being. We need some motivations for that individual to go and correct his or her path towards the better health. Again, not increasing sales, increasing better health determinant. Stanford, wouldn't you be less reliable in accessing the utility of clinical computing? Even 1972, what healthcare AI researchers have made greatest contribution? As of now, it is still going under the radar, and people are working. I just took a few names. There are the researchers who are working in the healthcare domain: Dr. Omar Manejwala, Dr. Julia Wright, and you can find all the associated people who are dealing with the healthcare in terms of mental health care and the emotional well-being of the individuals. So I see ethical problems in any healthcare provider using an algorithmic approach to try to monitor anyone's psychological state to increase billing of service potentially provided. I agree. In the United States aspect, I'm a Canadian citizen living in States. In Canada, I was involved with the Health Ontario, and in Ottawa, I presented an AI agent that was to alert any medical or administrative person when a heartbeat goes up and down more than 3 times, and that alert was an alarm. At that time in 2007, when I was conducting those experiments, Health Ontario took that on a serious note. Again, there is no billing happens in Canada for any such service that is potentially provided. In the United States, I agree that they will charge you. Have you seen a decrease in the stigmatism to seek mental health help? Since yes, absolutely. For the last 2 years, we have adopted the AI agents that extract the information out from our discussions between a patient and our nurse care coach, and we find those positive and negatives, and then we do the assertion or insertion in the discussion of the nurse or the person who's serving in some capacity to the patient to bring that person on track by showing their own discussions, by finding their own examples, or related to their same age, same neighborhood areas. And they might be densely populated, might be less densely populated. So Cassandra, I hope that answers. Eric, are your human coaches getting real-time feedback from AI during the live phone call? Not as of now. However, they do get the feedback right within next 40 to 45 minutes. Once that call is ended, it's not the basis on that call. We go with a priori, which is the Bayesian statistics application on the back end. Similarity index match from the previous discussions of the same age, same gender, same neighborhood, and that comes in 40 to 45 minutes because the data is extensive. We have like several millions of rows of attached to one topic only. So you can imagine, Eric, that this is still the evolution is happening. Thank you for asking this question. Monica, people often say that motivation does not last. Well, neither does the bathing. Yeah, absolutely. That's why we recommend it daily. So you are absolutely correct that the AI agent information does not last unless it has a priori. And whatever the AI agent extracts, that becomes a priori for something else. You are most welcome, Monica, and thank you so much for being here. So hopefully this allows you to go and learn more. So Monica and Itzel would hopefully gladly share these slides. And any questions, you are most welcome all to add me in LinkedIn. Back to you, Itzel or Monica.
Thank you, Atif. What a wonderful presentation. We really appreciate you today for sharing your knowledge with our attendees today. Just like you mentioned, we will be sharing all of your presentation deck as well as the pre-recorded message early next week. Well, you're more than welcome to stick around on the chat and address any additional questions. Otherwise, we look forward to connecting with you at Infotech. Thank you so much.
Thank you so much.
All right. Take care, everybody.
Take care.